Hello, hello. Great. Thank you so much for the invitation. I'm at work today. I was just covering the inpatient cell therapy service, and I will try not to be scattered. I have some slides as well, but I'm not a big slide person, so I have very few of them. But it somewhat keeps me organized about what we're going to talk about. If you can't see my slides, please let me know. But basically, I wanted to talk. Oh, good. I want to talk real briefly about myeloma bone disease because there was some continued information on that, and I like to mention it because this is something that is sometimes difficult to interpret for patients who don't have an opportunity due to geography or whatever to get in to see a larger myeloma center like Mayo Clinic, like NYU, that you've been hearing about from Maury and Faith. I want to talk a little bit about AlAmyloidosis. There's a new trial that came up at ASCO called the Andromeda trial. It was previously reported. They presented some updates, but again, sometimes the meaning of those updates wasn't actually clear to me until I started thinking about it more this spring. And then I'm on the inpatient service now again, and I get a lot of questions about precautions. How do I live my life? And what the CDC may say and how to go from there. So I wanted to talk about that real briefly. So when you think about myeloma bone disease, one of the largest, most recent analyses came from a side project or a companion trial with a very large Cassiopeia trial. This trial looked at daratumumab and Velcade, thalidomide, and dexamethasone. And I understand we don't use a lot of thalidomide in the U.S., but this is not that hard to change this one T to an R and call this Dara-VRD, which is something used in the U.S. Then patients receive transplant, consolidation for a little bit using the same regimen, and then randomized again to monotherapy or maintenance with daratumumab or Darzalex versus observation alone. This was compared to a similar line of just Velcade, thalidomide, and dexamethasone, transplant again, a little more consolidation for 2 cycles, and then again, that same randomization. So there are 2 randomizations in this trial looking at both the inclusion of daratumumab in induction and consolidation and looking at it in maintenance. Now, what's interesting, and the reason I'm talking to you about it today, is that along with this, they did a PET scan right before and right after consolidation. And this provides some of the background data about how to think about detecting myeloma bone disease. In this, the only thing I wanted to talk about primarily is the baseline PET-CT status. And, you know, no matter what arm you're on, it doesn't really matter what kind of treatment arm you're thinking about. The thing that I thought was interesting is basically 25% of patients are PET-CT negative. And that doesn't always mean that they don't have any myeloma bone disease. What it does mean is that they don't have a PET-CT that's positive. And PET-CTs often in the U.S. are performed so that a radiologist reads it, and they only read out what's positive, what takes up radioactive sugar in the patient's bones. And they may not comment on so-called lytic lesions that are PET negative, that are not active, that are not metabolically taking in sugar. And so sometimes radiologists just tell you what are the hot spots on your PET-CT, but they don't tell you all the things on your PET-CT. So when using a PET-CT, it's great that it looks at metabolic uptake because we can help enhance our understanding of response, but don't think of it that it's every lytic lesion is going to light up. It is unlikely to. And in fact, there are some patients where none of their lytic lesions light up, or many patients where just some of their lytic lesions light up on PET-CT. So PET-CT is not the end-all and be-all. And so Dr. Kaiser, who was on before, presented a relatively small study looking at whole body MRI and comparing it to PET-CT. Now, this is a little bit busy of a picture, but if you take it easy, you can just see broke down different parts of the body: cervical spine, thoracic spine, lumbar spine, skull, ribs, long bones, pelvis. And basically, at each one of these spots, the whole body MRI was much more sensitive at picking up evidence of myeloma than a PET CT. And actually, you can use diffusion-weighted imaging MRIs to add that intensity that the PET CT has into an MRI. But it's hard to do that. There's not a lot of whole body MRIs being performed in the U.S. There's a lot less MRIs with diffusion-weighted images performed in the U.S. So oftentimes in the U.S. you have, hey, do I do a PET CT? Do I do an MRI where I have most of my bone marrow in the lumbar and thoracic spine and pelvis? Or, or do I do a skeletal survey? And skeletal surveys are reasonable at looking at lytic lesions in your appendicular skeleton, your arms and legs, but it's not so good at your pelvis and spine. So I encourage patients to understand that a standard MRI that looks at your thoracic spine and lumbar spine and pelvis is going to be pretty sensitive in those areas, but it's not going to pick up lytic lesions that might be in your distal femur, like in and around above your knee at the end of your thigh or in your humerus. So that's the problem with MRIs as they're done now. PET CTs have approximately 20% negative rate, and so it's going to miss approximately 10% of patients who have myeloma bone disease, but it shows up not at all on their PET CT. And skeletal survey is difficult primarily because it doesn't pick up lytic lesions very well in your spine and your pelvis, and mostly just in your arms and legs. So this trial was great, and we're looking forward to have so-called whole-body low-dose CT available at more centers than it is currently available due to reimbursement challenges. And I think low-dose CT is certainly a very reasonable way to look for lytic lesions, even though it's only available in some centers across the U.S. Okay. The Andromeda trial. The Andromeda trial also got a small update at ASCO. It wasn't dramatic in any ways, and this trial was basically looking at the addition of Darzalex or daratumumab in combination with Velcade, Cytoxan, dexamethasone, and basically comparing all the lines in purple here to just VCD alone. So VCD plus Dara, and then following that up with more Dara, and looking to see how patients did. And it's important to realize when you looked at the overall updates, you were looking for essentially normalization of the light chains. Once you see those normalize, when you have a hematologic complete remission, that's really normalization of the free light chain levels. And that's what you're looking for, because in amyloidosis, your light chains are the things that are the primary movers and shakers in the majority of patients with AL amyloidosis, and those are the things that damage your heart and kidneys. And when you normalize them, that's your primary endpoint in the majority of AL amyloid patients. And you can see that the Darzalex plus VCD, Velcade, Cytoxan, Dex, versus VCD alone, there was a lot more patients that achieved early normalization, achieve normalization of their light chains, and that's what you want. And so that changes the way we think about AL amyloidosis, because we used to think, well, we would try to give them some initial treatment and then move right to so-called a consolidative autologous transplant. And now our standard is kind of shifted so that newly diagnosed AL amyloid patients aren't getting an upfront transplant, because if you can normalize their light chains, that allows them to potentially improve their cardiac and renal function, such that you think about autologous transplant primarily as an event you do at relapse rather than doing upfront when patients are still recovering from cardiac or kidney damage that led to the diagnosis of AL amyloidosis in the first place. Oftentimes, patients are treated sometimes with VCD or Dara VCD, occasionally even RVD. And it's important to realize that newly diagnosed AL amyloid patients sometimes have a lot of organ dysfunction, making the addition of Revlimid a challenge. And if Revlimid is given at a very low dose, I think it's reasonable to incorporate as upfront and been reported primarily by our colleagues in Greece. But this report here of Darzalex and VCD shows that this is very effective and has pushed us to move most of our patients with AlAmyloidosis to think about an autologous transplant only as second line. I'm on the inpatient service today, and I get this question so much, I can't tell you. Basically, they're in the hospital for something, and my myeloma patients are after my bispecific experience on a clinical trial, after autologous transplant with either high dose or intermediate dose melphalan, or after a CAR T for our center. We haven't done any commercial BECMA yet due to difficulty getting slots, but we certainly have had a number of CAR Ts done in a research setting, and patients ask me, and as I cover the cell therapy service, what kind of precautions should I take? What should I do? How should I live my life? Still the most impactful intervention I tell most people is communication, because it's quite common if you live this. You don't want to call us when things are going wrong because you don't want to hear what we have to say about potentially coming in and being evaluated. Certainly patients don't want to come back to the center. And so it's very common to have the patient say and instruct their family, please don't call because I don't want to hear what they have to say. So that's a challenge. It's an emotional struggle, and I hear it. I have not lived it myself, but it's got to be hard. And if there's any way that you can at least call us and communicate, at least we know what's going on and we might be able to move things forward positively. I tell patients after all these things, really eat what you like, but try to eat healthy. In the state of Georgia, where I currently practice, sometimes that's a challenge, but try to eat healthy if you can. Try to avoid things that could put you at risk. So for the only activity precautions I say to folks after significant immunosuppression, we don't really like lakes and ponds, right? Try to if you just dip your leg in, fine, but try not to dunk your head or swim fully in a lake or pond. Chlorinated water, salt water's fine. In strange activities, that full contact sports are really just not a great idea with patients with myeloma bone disease. Try to avoid chicken coops. This is one of the few things where organic free-range chickens, hey, that's a great benefit, but try to avoid areas where you can't breathe well and there could be infections. And then interesting pets are strange. So if you can avoid birds, snakes, lizards, we see these things, and sometimes they have some rare infections. And most importantly, in the setting of COVID, try to live your best unvaccinated life. I see patients right now are getting high-dose melphalan. I said, I just unvaccinated you with the high-dose chemotherapy. So no matter what you hear from the CDC right now, Dr. Walensky is not talking to you. So if you're outside, you don't need your mask the vast majority of time. But if you are entering a building you don't live in, go ahead, wear your mask. Don't eat inside a restaurant because you just can't eat with your mask on. It's just not a physical possibility. And sometimes this may change in your little microcosm where you live. Here in Georgia, we have, I think, about a 30% or 36% vaccination rate, which is not great. So there's still lots of COVID tooling along here. And honestly, COVID has taught us that excess hand washing, a lot of surface disinfection, all the other are kind of topical things that we do are sometimes, sarcastically called hygiene theater, and most of them don't provide a lot of infection protection. And finally, when can a myeloma patient take their mask off? Certainly, if people around you are actively coughing, that should make you worried about taking your mask off. If you're taking a regimen that has dexamethasone, or you've been exposed to dexamethasone in the last 30 days or undergone autologous transplant in the last 6 months, this certainly would make me concerned to take my mask off in an at-risk spot. And the at-risk spot are really buildings you don't live in, with people you don't know. And, somewhat a little bit controversial is that if you're a myeloma patient on Revlimid maintenance and you're 2 years out from transplant and you have circulating COVID antibodies, I would say go ahead, take your mask off, go inside a building, live like I do when I'm outside the hospital. because the circulating COVID antibodies, there's good, reasonable data to say that you have COVID antibodies circulating. You may not prevent infection, but you're not going to get sick from it. So these are just a couple notes that came up from ASCO and from my experience within patient service. Stop my share and look forward to hearing any thoughts or comments.
Okay, great. I think on your prior slide, my question was for how long? Like if you had the bispecific, the CAR T, the auto transplant, like for how long do you need to take those extra precautions? And then for how long afterwards should you get the COVID vaccine again? And then that's a very common question.
I think that's a common question, and I have not seen any published data on this. So it is my personal guesstimate alone. I have, there are some centers where we recommend that we try to give COVID vaccines 3 months out from transplant, and then try to look to see if somebody develops a COVID antibody that's circulating approximately 6 months out from transplant. And if they are, then we can tell them, hey, you have circulating COVID antibodies. If you're not on a dexamethasone-containing regimen, have at it. And I have not seen a real good, oh yeah, you're on a bispecific, and et cetera, because those patients are very hypogammaglobulinemic, or can be, and those patients who are after CAR T sometimes can also be very hypogammaglobulinemic, so they may need more individualized recommendations. But again, to my knowledge, there's no great data. It's a lot of by consensus at this spot.